Congenital structural lung disorders encompass a range of developmental anomalies that affect lung parenchyma, airways, and the diaphragm. Parenchymal or cystic lesions, such as congenital pulmonary airway malformation and bronchopulmonary sequestration, arise from abnormal airway branching or tissue differentiation during the pseudoglandular and canalicular phases of lung development. Airway malformations, including bronchogenic cysts, tracheomalacia, and tracheal stenosis, result from disrupted airway cartilage formation or abnormal foregut budding. Hyperinflation lesions, such as congenital lobar emphysema, create overdistended lung segments due to intrinsic or extrinsic bronchial obstruction. Diaphragm-related anomalies, like eventration, affect the mechanical function of the thoracic cavity and can secondarily influence lung development. The clinical spectrum ranges from incidental findings in asymptomatic infants to severe neonatal respiratory distress requiring immediate intervention. Understanding the type and location of these lesions is essential for predicting respiratory compromise, planning perinatal management, and coordinating postnatal interventions. Early recognition guides imaging, surgical planning, and monitoring for associated anomalies, ensuring that infants at risk receive timely, tailored care. Congenital pulmonary airway malformation originates from abnormal branching morphogenesis during the pseudoglandular and canalicular phases of lung development. The lesion consists of non-functional cystic or adenomatoid tissue that replaces normal alveolar structures, impairing gas exchange. Histologically, CPAM contains abnormal epithelium, cartilage, and smooth muscle, reflecting disordered airway differentiation. Genetic mutations contribute to lesion development, with KRAS and BRAF mutations implicated in types 1 and 3, and DICER1 mutations associated with type 4, which carries a risk of pleuropulmonary blastoma. The size, location, and type of CPAM determine the degree of prenatal lung compression and postnatal respiratory compromise. Large cysts can cause mediastinal shift, reduce functional residual capacity, and predispose to pulmonary hypertension. Recognition of the lesion prenatally or postnatally allows for risk stratification, planning for delivery in a tertiary center, and early surgical or supportive interventions. Understanding the developmental origin and structural characteristics of CPAM is critical for anticipating respiratory distress, associated anomalies, and long-term pulmonary outcomes. The Stalker classification categorizes congenital pulmonary airway malformations based on cyst size, histology, and associated clinical severity. Type 0 involves tracheobronchial or acinar dysplasia and is uniformly lethal due to absent alveolar structures. Type 1 lesions are the most common and contain large cysts between 2 and 10 centimeters. They carry a small risk of malignancy and usually present postnatally with respiratory distress or infection. Type 2 lesions have multiple small cysts and are frequently associated with other congenital anomalies, such as tracheoesophageal fistula, congenital heart disease, or renal abnormalities. Type 3 lesions are microcystic, appear solid, and often cause severe neonatal respiratory compromise due to compression of adjacent lung tissue. Type 4 lesions are peripheral, large, air-filled cysts with a DICER1 mutation association, which increases the risk of pleuropulmonary blastoma and necessitates lifelong surveillance. Understanding these categories is essential for anticipating clinical presentation, planning perinatal and postnatal management, and determining surgical urgency. The classification also guides prognosis, helping predict the likelihood of respiratory compromise, hydrops, and potential for malignant transformation, particularly in type 4 lesions. CPAM types are differentiated by their airway origin, cyst size, lung involvement, and associated anomalies, with severity increasing from type 0 to type 4. Type 0 arises from the trachea or main bronchi and is uniformly lethal due to absent alveoli. Type 1 originates from bronchial or bronchiolar structures, forming large cysts. These may be asymptomatic or produce mild respiratory compromise at birth. Type 2 develops from bronchiolar or alveolar tissue, is typically microcystic, and frequently coexists with other congenital anomalies, resulting in moderate neonatal compromise. Type 3 is solid-appearing, lobar, and causes severe respiratory distress due to compression of surrounding lung tissue. Type 4 originates peripherally, forming large cysts with risk for pleuropulmonary blastoma. Respiratory compromise ranges from mild to severe, depending on cyst size and residual lung volume. Across the rows, progression is evident in cyst size, degree of lung involvement, likelihood of associated anomalies, and potential malignancy risk. Higher airway origin corresponds with earlier and more severe neonatal compromise, while peripheral lesions tend to carry long-term oncologic risk. Recognizing these patterns helps prioritize monitoring, timing of surgical intervention, and family counseling on anticipated clinical outcomes. Prenatal evaluation of congenital pulmonary airway malformations relies primarily on ultrasound and, when needed, fetal magnetic resonance imaging. Ultrasound identifies cystic or echogenic lung masses, mediastinal shift, and in severe cases, fetal hydrops. The CPAM volume ratio, calculated by dividing lesion volume by head circumference, provides a quantitative measure of severity. A value above 1.6 is associated with increased risk of hydrops and more severe postnatal respiratory compromise. Fetal MRI complements ultrasound by confirming the diagnosis, assessing residual lung volume, and defining the vascular supply, which is critical for planning delivery and postnatal management. Early detection allows for risk stratification, anticipatory preparation for respiratory support at birth, and planning of surgical intervention. Large or microcystic lesions that significantly compress normal lung tissue require careful monitoring and coordination with a multidisciplinary team to optimize outcomes. Clinical presentation of congenital pulmonary airway malformation varies by lesion size and location. Neonates with large or centrally located lesions may present immediately with respiratory distress, cyanosis, mediastinal shift, or pneumothorax due to compression of surrounding lung tissue. Smaller or peripheral lesions may remain asymptomatic at birth and are often discovered incidentally on imaging. Beyond the neonatal period, infants and children may develop recurrent pneumonia, chronic cough, or spontaneous pneumothorax, reflecting impaired airway clearance or intermittent obstruction caused by the lesion. The variability in presentation underscores the importance of correlating imaging findings with clinical assessment, anticipating which infants will require urgent intervention versus elective monitoring, and ensuring timely referral for surgical planning when necessary. Diagnosis of congenital pulmonary airway malformation relies on a combination of chest radiography and advanced imaging. Chest X-ray may reveal cystic or solid lung lesions, sometimes mimicking pneumonia or pneumothorax. Computed tomography provides precise information on cyst number, type, and lobe involvement, and is essential for surgical planning. Imaging also helps distinguish CPAM from other congenital lesions, including Bronchopulmonary Sequestration, Bronchogenic cysts, and congenital lobar emphysema. The goal of imaging is not only to confirm the lesion, but to assess its size, location, and impact on adjacent lung tissue and mediastinal structures. This information guides perinatal counseling, anticipates potential respiratory compromise, and informs the timing and approach of surgical intervention. Accurate interpretation of imaging findings ensures that high-risk infants receive immediate support while minimizing unnecessary interventions in asymptomatic cases. Management of congenital pulmonary airway malformation depends on symptom severity and lesion characteristics. Symptomatic neonates, particularly those with respiratory distress, mediastinal shift, or pneumothorax risk, require urgent surgical resection, typically by lobectomy or segmentectomy, to relieve compression and restore effective ventilation. Asymptomatic infants are often scheduled for elective resection to prevent future complications, including infection, spontaneous pneumothorax, or malignant transformation, particularly in type 4 lesions with DICER1 mutations. Prognosis after complete resection is excellent, with most infants achieving normal respiratory function and low recurrence risk. Lifelong vigilance is required in type 4 lesions due to the risk of pleuropulmonary blastoma, and careful follow-up is advised to monitor for late complications or associated anomalies. Early identification, appropriate timing of surgery, and multidisciplinary perioperative care optimize outcomes and minimize the impact of CPAM on long-term pulmonary health. Bronchogenic cysts arise from abnormal budding of the embryonic foregut, typically during the 4th to 5th week of gestation. The cysts are lined by respiratory epithelium and contain cartilage, smooth muscle, and mucus glands, reflecting their origin from airway tissue. They most commonly localize in the mediastinum, though they can also occur within lung parenchyma or, rarely, in cervical or abdominal locations. The size and location of the cyst influence clinical significance. Mediastinal cysts may compress the trachea or major vessels, producing respiratory distress at birth, while intraparenchymal cysts may remain asymptomatic until later in infancy or childhood. Understanding the embryologic origin and structural composition explains both the potential for airway obstruction and the rationale for complete surgical excision, which eliminates mass effect, prevents infection, and mitigates the small but real risk of malignant degeneration. Bronchogenic cysts present variably depending on size and location. Neonates may exhibit respiratory distress, stridor, or difficulty swallowing when mediastinal cysts compress the trachea or esophagus. Older children and adults often present with recurrent pneumonia, chronic cough, or incidental findings on imaging. Diagnosis combines chest radiography and cross-sectional imaging. A chest X-ray typically shows a solitary, round, water-density mass, while computed tomography or magnetic resonance imaging defines cyst borders, internal characteristics, and relation to adjacent structures. Imaging also helps differentiate bronchogenic cysts from other congenital lung lesions, such as CPAM, congenital lobar emphysema, or intrapulmonary sequestration. Early and accurate identification allows for timely surgical planning and anticipation of potential airway compromise or complications from infection. Complete surgical excision is the standard management for bronchogenic cysts, regardless of symptom severity. Removing the cyst prevents airway compression, recurrent infections, and potential rupture. Although the risk of malignant transformation is low, excision eliminates this possibility and reduces long-term morbidity. Outcomes after complete resection are excellent, with most patients achieving normal respiratory function and minimal post-operative complications. Early intervention is particularly important for mediastinal cysts that threaten airway patency, while asymptomatic intraparenchymal cysts are also resected electively to prevent delayed respiratory compromise or infection. Careful surgical planning, guided by imaging, ensures safe removal while preserving healthy lung tissue and avoiding injury to adjacent structures. Congenital lobar emphysema results from a ball valve mechanism that leads to progressive overinflation of a lung lobe. Obstruction may be intrinsic, such as deficiency of bronchial cartilage, mucus plugs, or bronchial atresia, or extrinsic, including compression from vascular structures or adjacent lesions like bronchogenic cysts. CLE predominantly affects males, with a reported incidence of 1 in 20 to 30,000 live births. The overinflated lobe compresses surrounding lung tissue and can cause mediastinal shift, impairing ventilation and oxygenation. Understanding the pathophysiology clarifies why some infants present with early respiratory distress, while others remain asymptomatic until later in infancy. Recognition of the underlying mechanism guides clinical management, including the decision between careful observation and surgical lobectomy for symptomatic cases. Infants with congenital lobar emphysema may present with respiratory distress shortly after birth, including tachypnea, cyanosis, and wheezing. Physical examination often reveals a hyperresonant chest on the affected side, diminished breath sounds, and mediastinal shift toward the contralateral lung. While most cases present within the first days of life, milder lesions may remain asymptomatic and only become apparent later in infancy or childhood due to recurrent respiratory infections or incidental findings on imaging. Recognizing these clinical features allows prompt evaluation, ensures appropriate respiratory support, and informs the timing of imaging and surgical intervention for symptomatic infants. Diagnosis of congenital lobar emphysema relies on imaging studies that reveal overinflation of a lobe and compression of adjacent lung tissue. Chest X-ray typically shows a hyperlucent, overexpanded lobe with mediastinal shift. Computed tomography further characterizes the affected lobe, distinguishes CLE from other congenital lesions such as CPAM, pneumothorax, or bronchopulmonary sequestration, and identifies potential extrinsic compressive factors. management is guided by symptom severity. Symptomatic infants, particularly those with respiratory distress or compromised oxygenation, usually require surgical lobectomy to relieve compression and restore effective ventilation. Asymptomatic or minimally affected infants may be monitored closely with serial imaging and clinical assessment, as some lesions remain stable or improve with growth. Surgical outcomes are excellent, and compensatory growth of the remaining lung tissue is common, supporting adequate long-term pulmonary function. Bronchopulmonary sequestration arises from abnormal budding of the primitive lung during the pseudoglandular stage of development. The lesion consists of non-functioning lung tissue that has no connection to the tracheobronchial tree and receives its blood supply from a systemic artery, most commonly arising from the thoracic aorta. The location and type of BPS influence clinical presentation. Intralobar sequestrations are integrated within normal lung tissue, drain via the pulmonary veins, and often present later in childhood with recurrent infections. Extralobar sequestrations are encased in their own pleura, frequently located near the diaphragm, and drain into systemic veins. These are more often associated with other congenital anomalies, including congenital diaphragmatic hernia, cardiac defects, or genitourinary malformations. Understanding the embryologic origin and vascular characteristics is critical for accurate diagnosis, prenatal risk assessment, and surgical planning to prevent complications such as infection, hemorrhage, or respiratory compromise. Bronchopulmonary sequestration is divided into intralobar and extralobar subtypes, differentiated by pleural coverage, venous drainage, and clinical presentation. Intralobar sequestrations lie within the lung parenchyma, share the visceral pleura, and drain via the pulmonary veins. These lesions often present later in childhood with recurrent pneumonia or chronic cough because the abnormal tissue becomes infected or compromises local airway function. Extralobar sequestrations are completely separated from the normal lung by their own pleura and typically drain into systemic veins such as the azygos or inferior vena cava. They are more frequently associated with congenital anomalies, including diaphragmatic hernia, cardiac defects, and genitourinary malformations. Hybrid lesions with features of both BPS and CPAM are also reported. Recognizing the subtype is essential for surgical planning, as intralobar lesions require careful dissection within the normal lung, whereas extralobar lesions can often be excised independently. The systemic arterial supply, location, and associated anomalies guide both timing and approach for resection, minimizing post-operative complications. Prenatal identification of bronchopulmonary sequestration relies on ultrasound and fetal magnetic resonance imaging. Ultrasound typically demonstrates an echogenic triangular mass, most commonly in the left lower lobe. Color Doppler confirms a systemic feeding artery, which is the hallmark feature distinguishing BPS from other congenital lung lesions, such as CPAM. Fetal MRI provides detailed information about lesion size, residual lung volume, and vascular anatomy, which is crucial for delivery planning and postnatal surgical intervention. The CPAM volume ratio may also be calculated to assess risk of hydrops in large lesions. Early prenatal recognition allows multidisciplinary planning, ensures delivery at a tertiary center with surgical and critical care capabilities, and informs counseling regarding potential respiratory compromise and timing of postnatal resection. Postnatal presentation of bronchopulmonary sequestration varies with lesion size and subtype. Neonates may be asymptomatic if the lesion is small, but large intralobar or extralobar sequestrations can cause respiratory distress due to mass effect or pulmonary hypoplasia. In older children and adults, intralobar lesions often present with recurrent pneumonia, chronic cough, or hemoptysis. Imaging is essential for diagnosis and surgical planning. Chest X-ray may show a posterior basal opacity, but computed tomography, angiography, or magnetic resonance imaging is necessary to map the systemic arterial supply and venous drainage. Precise delineation of the feeding artery is critical to avoid intraoperative hemorrhage and ensure complete resection. Postnatal imaging also helps distinguish BPS from other congenital lung lesions, such as CPAM, CLE, or bronchogenic cysts, guiding the timing and approach of surgical intervention. Surgical resection is recommended for all bronchopulmonary sequestrations to prevent infection, hemorrhage, and the rare risk of malignant transformation. Intralobar sequestrations require careful dissection within the lung parenchyma to preserve healthy tissue, while extralobar sequestrations can often be removed independently due to their separate pleura. Outcomes are excellent when resection is complete, with most patients achieving normal respiratory function and minimal long-term complications. Extralobar lesions carry a higher likelihood of associated anomalies, necessitating multidisciplinary follow-up to monitor for congenital heart disease, diaphragmatic defects, or genitourinary anomalies. Early identification and appropriate surgical planning minimize perioperative risk and ensure the best functional and developmental outcomes for affected infants. Diaphragmatic eventration occurs when the diaphragm is intact but underdeveloped or thinned due to incomplete muscularization. The resulting dome-shaped elevation can reduce thoracic volume and, in some infants, cause respiratory compromise, although many cases are incidental and asymptomatic. Clinical presentation ranges from mild neonatal respiratory distress to no symptoms at all. Management is determined by severity. Asymptomatic or mildly affected infants can be observed, while those with significant respiratory compromise may require surgical plication to flatten the diaphragm and restore effective lung expansion. Recognition of the condition and its functional impact is critical for anticipating ventilatory needs, particularly during the neonatal period, and for planning postnatal monitoring and potential surgical intervention. Tracheomalacia results from structural weakness of the tracheal cartilage, leading to dynamic collapse of the airway during expiration. This collapse increases airway resistance, producing stridor, wheezing, and intermittent cyanosis, especially during crying, feeding, or respiratory infections. The spectrum ranges from mild cases, which may be asymptomatic or improve as cartilage strengthens with growth, to severe cases causing life-threatening airway obstruction. Underlying causes include congenital malformation of the tracheal rings or external compression by vascular structures. The collapse can compromise effective ventilation, predispose to recurrent lower respiratory infections, and make weaning from mechanical ventilation challenging in neonates. Management is tailored to severity. Mild tracheomalacia is managed conservatively with humidified air, positional therapy, continuous positive airway pressure, and treatment of coexisting conditions such as gastroesophageal reflux. Severe cases may require surgical intervention, including aortopexy to lift compressing vessels off the trachea or airway stenting to maintain patency. Multidisciplinary monitoring is essential, with pulmonology, otolaryngology, and surgical teams coordinating care to ensure adequate oxygenation, support normal lung development, and minimize long-term complications. Congenital tracheal stenosis is a fixed narrowing of the trachea, often caused by complete tracheal rings that encircle the airway. The severity of stenosis ranges from mild narrowing, which may be asymptomatic, to critical obstruction that can cause severe respiratory distress, cyanosis, or failure to wean from mechanical ventilation. Infants may also experience recurrent respiratory infections due to impaired airway clearance. Diagnosis is established using imaging, such as computed tomography or bronchoscopy, which provides precise information on the length, location, and degree of narrowing. Management depends on the severity and symptoms. Mild cases may be observed with supportive care, including supplemental oxygen, careful monitoring, and treatment of coexisting conditions. Severe cases require surgical correction, typically through resection with primary anastomosis or slide tracheoplasty, designed to enlarge the airway while maintaining structural integrity. Early recognition and detailed preoperative imaging are essential to reduce perioperative risk, restore effective ventilation, and support normal respiratory development. Prenatal evaluation of congenital structural lung disorders allows anticipation of postnatal respiratory compromise and planning for intervention. For cystic lesions like CPAM, a CPAM volume ratio above 1.6 predicts a higher risk of hydrops. In Bronchopulmonary Sequestration, identification of a systemic feeding artery confirms the diagnosis and informs surgical planning. Diaphragmatic eventration can often be distinguished from true CDH, allowing more accurate prognostication. Fetal magnetic resonance imaging is used to assess lung volume, lesion size, and vascular anatomy, providing detailed information for delivery planning. Multidisciplinary coordination among obstetrics, neonatology, pediatric surgery, and, when relevant, cardiology ensures that infants are delivered in a tertiary center equipped to provide immediate respiratory support, ECMO if necessary, and timely surgical intervention. This approach improves survival, allows structured postnatal care, and ensures families are counseled on potential complications, expected interventions, and long-term follow-up requirements. Congenital structural lung disorders encompass a spectrum of lesions affecting the lung parenchyma, airways, and diaphragm. Congenital pulmonary airway malformations are the most common, classified by the Stalker system, and generally require surgical resection to prevent respiratory compromise or malignancy. Bronchogenic cysts arise from foregut maldevelopment and are cured with complete excision, which prevents infection, airway compression, and the small risk of malignant degeneration. Congenital lobar emphysema results from a ball valve obstruction causing overinflation. Symptomatic lesions require lobectomy, while asymptomatic cases may be monitored. Bronchopulmonary sequestrations are supplied by systemic arteries and should be resected even if asymptomatic, with attention to associated anomalies. Diaphragmatic eventration involves a thinned but intact diaphragm, typically with a better prognosis than CDH. Tracheomalacia and tracheal stenosis may cause recurrent stridor, wheeze, or respiratory distress and occasionally require airway surgery. Across all lesion types, vascular supply, lesion location, and associated anomalies are key factors for differentiation, risk assessment, and planning of perinatal and postnatal management.